Good morning to the full hall of chairs here. So, actually, the rules of selection for to make a patient 20 happy, which is the most important thing, yeah, has to be based on various parameters. So, I would like to look at ocular variations. We will look at lens based variations. We look at patient variation, and then requirement based variation, and surgery based variations. So most often when we think about how to select a lens, astigmatism is the most important thing that is being talked about. But true, but now with the advent of toric lenses, we can always correct the astigmatism with the help of toric lenses. So it's not very difficult in a patient with a, planning for a trifocal or a EDOF lens. We can use astigmatic correcting lens to make sure that they get clear vision. But the most important thing will be the ocular surface, which is the most important thing, which is often missed out, and other pathology of the endothelium of the cornea, which is often overlooked. So the most important thing is, please look at the ocular surface to make sure the patient has a clear ocular surface, so that they get a good quality of vision post cataract surgery, without which a multifocal, a trifocal of a EDOF lens will misfire. The most important thing is, look at the meibomian gland, if possible evert the eyelid, because most of the patients whom we are operating are elderly patients, and meibomian gland dysfunction is very common in our population. So don't underestimate, if you use even a normal intraocular lens, the significant amount of higher order aberration created by the changes in tear film can make a monofocal lens laughable. This is a look at how much of tear film dysfunction can cause variations in clarity. So if you look at the first picture with the normal tear function to a very severe dysfunction, you can see that the quality of vision drops significantly. When you look at this picture, this is the eye blink time. So when you see the tear breakup time over a period of few seconds, you can see that the higher order aberrations increases exponentially. Actually, you will think that this may be a keratoconus, but it is not, it is a dry eye. So what to do? Always look for the dry eye in patients whom you want to do any higher end intraocular lens, even a monofocal lens. If possible, treat the dry eye. So if you can't treat it, better to avoid the trifocal lenses or a multifocal lenses. Make a good slit lamp evaluation mandatory in your practice, because if you miss these guttata or other endothelial pathologies, you might end up with a subclinical corneal edema, and then patients will say that the vision is not clear, they get more glares, they get more halos, especially driving. It becomes very big problem. So always the other factor to look at, patient factor, is the pupil size. So you can use a mixed match of lenses according to the pupil size. A patient having a higher pupil size will do better with a monofocal lens in the dominant eye and a trifocal lens in the non-dominant eye. Don't use EDOF lenses in people with a bigger pupil. So I will come to that later. So if it is a irregular astigmatism, it is a clear no-no for any of these refractive lenses. So when you look at the biometry, I don't want to emphasize that you need to have a good biometry, but one thing which I found was that never rely on a single formula. Even with this good high-end optical biometers what we have today, what happened to me was a patient whom the Barrett formula gave one value and the SRKT gave another value. I went with the Barrett formula because I was using Barrett formula only, and then I was in for a surprise. The reason being is, in that patient the Y to white was calculated by the measured by the IOL biometry was around 7 millimeter. So the Barrett formula gave a different IOL value for that patient, but when I looked at the SRKT, which is much closer to normal. So this is a very important point which I want to say here is, if you are using any optical biometer or any measure, please use two of the formulas, but it should be from different generations. The reason being is, though SRKT may not be as accurate as Barrett, but the thing is, it takes into value of few of the parameters like white to white, and ACD is not a very big parameter in SRKT. So you will get a comparative value. So always don't get stuck to higher end formulas. Always look at SRKT also, just to make sure that we are closer to normal with any of the current generation, the second or third generation formulas. So in any patient or any eye, within patients, variation is the rule, as Darwin told. So what type of lens can be used for personalization in these patients? We want to give them glass-free vision. That means that 20 happy patients. So it's not 20/20 or N6. So the options are, don't throw away the monofocal lenses. It is mandatory to have monofocal lenses also in your practice when you want to do mix and match in patients with variations. So use of trifocal lenses is very important. Extended depth of lens, it's not like it doesn't have a problem. I will go to that later. No IOLs is exempted. Selection must be tailored to each patient and each eye. So why not monofocal lenses? We have seen that so many patients whom we have done a PMMA lens or a spherical lens, they read very well, almost N8, and they have very good distance vision of 6.9, even 6.6 partial. So even a good spherical lens in a small pupil will make an EDOF laugh. EDOF is an exaggerated spherical lens. Remember, EDOF is nothing but an exaggerated spherical lens. So monofocal IOL, where I am using monofocal IOL, use it in a dominant eye when somebody is a vivid driver, they want to do all work at night, they have mild amblyopia in one eye. So all those patients will benefit from a monofocal lens in the eye which have these problems, or they don't want any problem. So either of these two. So when somebody says, I am not having so much of money, but I would like to have a vision that can both see distance and reading, don't forget to use the monofocal lenses, where you can think about giving them a good monofocality, where we can have one eye for distance, that's the dominant eye for distance, and the non-dominant eye for reading. So how to tweak asphericity? Asphericity is the one we talked about 20 years back, and now that we have gone back making spherical lenses in the name of EDOF. When you look at driving, it gives you a lot of power in terms of clarity of vision, especially nighttime vision. We can use a prolate or oblate corneas to select whichever lens you want to choose. If you want to choose a lens for older patients, Panoptics or a Technics or a Vivinex is better, but if it's for a younger patient, I find AT Lisa, which is the one thing which I use, seems to be better because it has a spherical value. And then when we come to drivers, we always think that EDOF is better. It is a misconception. EDOF is not better. We have to be very selective in EDOF. Many drivers and many patients feel the distance vision is blurred if you use a EDOF lens. So the key is pupil size. It is a mesopic pupil size of 3 millimeter. You can more than 3 millimeter. If you look at these presentations, you can see how different it is. This is a monofocal IOL in the multifocal in the left, and then you can have a EDOF in the right. So you can have lot of these glare which can be very different from multifocal. So it's not zero, so the EDOF patient also feels glare. So this is again the same thing. You can see the light here. This has a halo here in a multifocal. Again in the EDOF, it also has some kind of a glare and a halo here. Its only difference is the halo is slightly different. It's not predictable. It's not exactly what we see. You will get it. So that's the reason. This is another picture where we need to see how the EDOF performs. You can see that the EDOF tend to have the mesopic vision, the intermediate distance also drops significantly. So it's not like EDOF patients are happy with intermediate vision. And some of these trifocal lenses, you can see that the intermediate vision is good, the starting distance vision is good, and reading vision is good. If you look at this graph here, you can see that there is a great drop in distance vision with the EDOF lenses. Remember, there is a great drop in distance vision with EDOF lenses compared to even good trifocals. So we have to be very careful in selecting EDOF for a driver. So post-refractive surgery, I would like to say that post-myopic refractive surgery, you can use a more negative Q value like a Panoptics. For a hyperopic, you can use a more positive Q value lens. So surgical considerations for being happy is precise centration of IOL, good phacosurgery, which I don't want to mention because it's all talked about. So especially centration is more important for EDOF lenses. The current generation trifocal lenses tolerate up to 1.5 to 1.8 millimeter of decentration. So complete decentration is very bad. Use of Purkinje images for centering as a guidance. So mine is all talking about thing. This is a very small thing. Whenever you put in a multifocal lens or something, you always try to center it and then always try to dial that. So always dial the lens to center it. Always make sure that the Purkinje images are at the center. Also, when you dial the lens, if this rhexis is slightly eccentric, align the haptic along the place where your rhexis is oblique. You can use this air bubble to see that the Purkinje images are centered on the IOL. So, and most important thing is, if you find that the anterior chamber is shallowing a little bit, it is always better to fill some air. This is very, very important in toric lenses and trifocal lenses, because there is no post-operative shallowing, so you don't get inadvertent optic capture of the optic, or little misalignment of the lens or a decentration of lens. You can always put in a little bit of air bubble. So this is the only thing. And oblique rhexis, better to align the lens haptics along the oblique axis of your rhexis. So avoid optic capture until, that's why I am saying, like at the end of the surgery you can put a little bit of air, fill the air, so that there is no decentration or optic capture. So conclusion is, don't pre-select your lens. Okay, somebody walking in, he is a rich patient, don't think that patient is a computer engineer, we are going to do this lens. So don't pre-select IOL before all the data in your clinic is available, because then only with all the data, as I told you, from the cornea till the biometry and what surgery you are planning, we can choose the best IOL for the patient. Always keep options open. Thank you.
Thank you, Dr. Arvind.
Yeah, Dr. Sharma's a wonderful talk. Small practical problems when we in the OP. Sometimes patients come with a multifocal in one eye, done elsewhere, and you don't have what lens, and you don't know what type, what make, what technology they've used, whether diffractive, apodized, or old technology, or whatever. In that case, what is your suggestions in the other eye?
This is a good question. When we look at the lens as experienced surgeon, we will know whether it is at least a diffractive lens or a EDOF lens. That we will know.
Only.
So in any way, if they are happy, most important thing is they are happy with the vision or not. If they are happy with the vision, then probably I will do a say, if it is a diffractive lens, I will do a diffractive trifocal for the patient, and maybe at the price point what they want. So if they don't want to spend much, we can give a trifocal Indian origin, or if you want to do it, they want to spend more, you can do a premium trifocal lens.
Yeah, I think that's important point, that first understand whether the patient is happy. First, what I ask is whether the patient is really happy with the vision, and in case they are so, you can
yes, sir, we can plan a diffractive.
And another instructions mostly I give is, ask them not to compare one eye and the other eye post surgery of the other eye, so that the adaptation, neural adaptation.
Yes, sir, that is always true with even monovision or a trifocal or a multifocal.
I think these 2 points very important when you don't know the what make is the other eye, and patient still wants multifocality. If the patient is unhappy or complaining, or there is any residual refractive in the other eye, maybe you can go with the monofocal.
Yes, sir.
Thanks a lot, Dr.